Dr. Jim Leavitt from Gastro Health. Thank you so much for joining me today. I welcome you to this conversation. And
Well, thanks for inviting me.
yeah, absolutely. How are you and how are things with Gastro Health?
Well, me personally, I'm fine. Like I said, no cough, no shortness of breath. Life is good. Um, I'm home, as you can see, and after I'm done with this, I'll be doing my televisits for today. So for me, I'm fine. My family's fine, so that's always a good start. Um, as far as gastro health, obviously, like everyone else, things have changed. Our numbers, our volumes went down dramatically. We closed several of our centers, our surgical centers. We kept open strategic ones just to do urgent cases. For example, we did a case. I had a 69-year-old woman with 2 months of progressive dysphagia and 20-pound weight loss. We had to do that endoscopy. But we went from maybe doing in these two centers that are next to each other 500 cases a week to 15 cases a week at one point. Our numbers went down, and we furloughed about half our staff. We but but it was an interesting thing. Necessity is the mother of invention. So one of the things that we wanted to do was start to look at televisits and ramp them up. Boom, we've done that. So within about 10 days, we rolled out televisits across Gastro Health, and in Florida alone, at one point, we were doing 6,000 televisits a week. So it was an interesting experience. The other part that was affected was we have done a lot of deals, and so we brought a lot of groups on board, and we standardized our platform, so everyone was on one platform. We had to slow that down because we couldn't travel to other places to really bring them on into a single platform. So that made it a little bit, and so there was a nadir. And now we're back. We're over 50%. We've opened up a lot of our surgical centers are starting to open up across the country. We're over 50. We're about 50% to 60% now back to where we were. So things are starting to pick up. We're starting to see patients back in the office, although still, I think televisits are the dominant way of seeing patients for most of us still today. Part of that is us, and part of that is the patients.
What you're doing is it different in Florida versus elsewhere? So you have
Yeah,
practices in other.
yeah, exactly. So if you look, I'm in Miami-Dade County. So I think there's been like 60,000 cases, COVID cases reported in Florida. A third of them are in Dade County
Mhm.
alone, right? If you go to Birmingham, Alabama, now the numbers are starting to pick up there, but it's still relatively low, right? And so obviously the effects have been somewhat different, but everybody dropped. There was no one that stayed the same. Everyone had a significant drop. I think the rate of return has been different based on the prevalence of the disease and the incidence of the disease in that particular area. So I think that's what's being affected, the rate of return.
Mhm. What is happening right now as far as PE deals are concerned across the board, based on what your sense is and what you know?
Yeah. So first thing I want to say, it's very interesting um, that how people think of this. Um, like, what's the effect of COVID on private equity? Right. That's what you want to know. Well, I'm not private equity. I'm a company that's partnered with private equity. So you asked me what the effect on my company is. Now, what's the effect of private equity companies? I can talk about that, but that's probably not what your audience is interested in. But there's two different things, right? So private equity, obviously, if they have multiple platform companies, they're out there helping the companies. Cash is king. They're really digging into the 13-week run outs to see how what their cash positions are and things like that. And we're doing that also, but that's internalized. And so we're still a healthcare company. We deliver healthcare. That's what we do. And we have a private equity partner, which has been very beneficial through this time for us in many ways.
In what ways has it been beneficial?
We'll hire a healthcare law firm, a national one, but they'll use it for all their healthcare platforms,
Mhm.
right? So we have ability to get to real experts on things. They help us find the technology that we can onboard on, we can use onboarding. So our we're capitalized better. We have better relationships with banking. We could get a revolver line of credit more easily. So um, and they have expertise that they can bring to us above and beyond. So I think that we're actually more secure in many ways than the average 4-person group out there who is struggling more. So I think it's helped us in a lot of ways like that.
Are you pursuing any physician practice deals in the current times?
Yeah, we still have a pipeline that's active. We still are talking to a lot of groups. We're signing NDAs and letters of intent. Um, we're doing due diligence on deals that were in the pipeline right now. So all those things are progressing.
Mhm.
Um, the closing date, we'll see. But the processes themselves are still ongoing.
Our valuations are taking a hit because of COVID-19.
Yeah, that's a hard question. So I guess number one, it depends on where you are in the process with the group.
Hmm.
Number two, we think it's if you had to close right now, would they take a hit? Yeah, it's hard to figure out what the valuations are, and it's harder to get lenders to feel comfortable with your valuations when they see 60 or 70% drop in revenues right now.
Hmm.
And so you have to convince them that the revenues are going to come back and what's the plan is. So it's a more difficult process. And do I think you might see a decrease in multiples? Again, I'm not a soothsayer. I don't know. But my guess is it might be, because the valuations might be similar, but the multiples, the when you might be lower, because the multiple is just an expression of risk, right? Uh, so there's more risk out there right now, and so I wouldn't be surprised if you saw some diminution in the multiples.
If you wear the soothsayer hat and see into the future, what are some short-term and long-term effects that practices in this space will face?
So I think from the practices point of view, the short-term effect is stay safe, keep your patients safe, do the right thing. Make sure you understand what you have to do to do that. It's still all about the patients and your staff, and do that. That's still deliver great care, ramp up your televisits, and hope that that's something that the government will allow and stay, and payers will pay for at a reasonable rate in the future. That's number one. Number two, short term, is look at your cash flows, make sure you can stay in business. We're not the U.S. government. We don't print money. So that's, we have we have some rate limiting steps there. So understand, for example, one of the things that we did is we built a calculator for each care center and each surgical center. So we knew what our volumes needed to be to break even. And then from there, we could understand our cash flows and where we could go out to. So short term, really act like a business. And there'll be some people hurting. So long term, depends on where you are. Do your financial planning and your planning around patient volumes, understanding and hoping that our goal is to get to 75%, 70 to 80% by the end of the year. And what's the financial outcomes on that? How can you start thinking long term? How can you run your practice more efficiently? I think all of us have learned that there's more efficiencies that we can do. You can do more with less, actually. Like I said, necessity is the mother of invention. So how can you return even stronger and better? What are the things that we can put in place, or we already put in place, that we can leverage into the future to make us a better company and provide better care? So I think that's what you have to think of. And I think there's going to be some suffering in some groups that aren't going to be capable of doing this. From the private equity point of view, we'll see. We know we're already getting inbound calls from people saying help.
Mhm. If you were on the outside, right, like, so you were not part of a private equity backed platform, and you were an independent practice right now, and then we go to the end of the year, and your finances are not looking good. What would you do? Would you look at private equity, because it's, you're in a bind, right? Because if you look at private equity or a PE backed platform, then your valuations are not high. So you'll probably sell out at a valuation which would be probably far lower than pre-COVID days. But if you don't do that, you're struggling financially. How do you go about your decisions, and what would you do?
Yeah, you have to look at, there's many different options, and one size doesn't fit all, obviously. It depends on how. So if it's a choice between doing something or going out of business, you do something. Um, or if you're 68 years old and you can retire and you're a solo practice, maybe you retire. I don't know. But there's a lot of options. I think that, and then there's the hospital. I think the hospital is one of the reasons that doctors are consolidating, is they don't want to join the hospital. I think there's a lot of problems joining a hospital. I think that physicians are consolidating one way or the other, and have been for a number of years, because it's the best model for us. It's our obligation to lead healthcare reform. We're the best advocates for patients. So I think that this may be uh, a wake-up call to some people to say, maybe I need to find a place to consolidate. And my argument would be, it's not the hospital, because that usually raises costs. It's a problem, and you're now employed in a way that your contract is good for 2 years, and then you get a new contract, and they could say goodbye, etc. But in our model, or with other groups, hopefully this spurs consolidation. This gets us to a place where we can lead healthcare reform, and do what's right for the patients and ourselves.
So, as a practice, if revenues are going down, what are some steps that you can take?
Yeah, so I think there's two sides of the equation. It's what's coming down on the bottom, right? That it's important. It's what the profit is, and so we may say, hey, for a while, we're going to get to 80%. So if our revenues, top line revenues, are 80%, I think there's a lot of, if we can affect some efficiencies in our practices and decrease costs and overhead, then we can still have a good bottom line. So I think we need to start looking at that from a business point of view, not just a functional point of view. Simple. If we're going to be, if 25 to 35% of our visits are going to be televisits, do we need as much real estate? Can we start decreasing or consolidate? If we, for example, Gastro Health, can we start consolidating some of our care centers and offices, and so we don't need as much space, so we can reduce rent and also reduce personnel and things like that. So I think there's opportunities from an efficiency point of view, so that if revenues are down a little bit, we know now that we can do with less and be more efficient. And if we apply those two standards, we're going to do all right.
Well, for a private equity backed platform, what are the risks that they carry in a time like this? Especially in a time like this.
Well, so the business doesn't come back, right? You're over leveraged. So a lot of these when we purchase groups, we borrow money. It's leveraged. So if you're in a position where you're very leveraged, i.e., you have a lot of debt, and then the revenue that you bought decreases significantly, you're over leveraged. You don't. It'd be like if you had a $500,000 mortgage in your house, but you were making $800,000 a year, you wouldn't worry about it. If you had a $500,000 mortgage in your house and somehow you lost your job and you could only make $70,000 a year, you have a problem. And so that could be a problem in with this. If you are already over leveraged and you don't have a good comeback for your revenue stream, you could be in trouble. And that's the risk that's going on, not just in private equity, certainly in private equity, but in public companies. I mean, part of a lot of this news out there is about how public companies and other companies have used debt, and they're so much in debt. That's why what's happened to Hertz, et cetera, right?
Yeah.
So we're subject to the same things as the rest of the business world.
There's been plenty of media attention towards private equity led medical practices, and a lot of that is negative. I'm curious to hear from you on what you have to say.
Yeah, so you can always find a few bad apples in the barrel, right? And so if you're the media and you just want to concentrate on the bad apples, that's fine. But there's way more good apples than bad apples. And so I would say we all know most physicians care about their patients and care about doing the right thing and giving great care. And we all know physician groups or physicians, whether they have private equity backing or not, they're very money focused, and they do things that we wouldn't necessarily look at in a good light. And so I know for us, we're very mission driven and not margin driven. But we're all, I mean, every medical practice is a for-profit company. There's no shame in that. But if you're mission driven, then that's what you want to be. And so we're very mission driven. We remain mission driven. So I know we've done great things. So we've markedly increased our ADR rates. We've done episodes of care around colonoscopy and EGD, and we're like in Florida, where 75 to 85% of the average cost of an episode of care all costs 3 days before and 14 days after for colonoscopy and EGD, compared to the rest of the state. We do look at expenses. We don't try to just drive revenue. So when we brought in a group, and the number of bottles that they did per case, pathology, because they had a little small path lab, was way out of line, and we brought them back into line because we want to do good medicine and give good care. And so I'm proud of what we did. And I know I'm friends with a lot of people who've done private equity deals and been platform companies, and I know they feel the same way I do.
Mm-hmm. From your lens, how do you see the future change? At some point we'll be out of COVID, and this will be behind us. And how would GI have changed by then and beyond that?
Yeah, so I think we're going to be more efficient. I think it's going to help us. I think we're going to be able to run our businesses more efficiently out of necessity. I think that patients are going to have different expectations of safety. I think that while in the next 2 or 3 years, I can't tell you 10 or 15 years from now, I don't think you're talking about that future. But I think patients' expectations of safety will remain very high, and you're going to have to prove to them that you care about that. I think televisits will, as long as the marketplace stays with some reasonable reimbursements, I think it's here to stay. And so we can devise our strategies around that. I think we're looking at really cool ways of new and different ways of patient engagement that are going to be aided by technology. I think all those things are going to be very important. More touch points remotely. using predictive analytics to be able to know when to touch the patient correctly. That's what I think is going to happen. So that I think we're not going to. I think this will spur us to do things. So we're not going to wait till the patient's in crisis. What can we put in place now to touch the patients in ways other than just bring them in the office? I think this taught us a good lesson. I
Mhm.
think that's where GI and healthcare is going to be going.
The way I see it, a lot of trends that were already underway pre-COVID are probably accelerating right now, right? Like, so telemedicine was there before, AI was there before. And maybe DNA testing, it was there before. I'm guessing that all these technologies will accelerate and change the demand supply equation in gastroenterology. Until now, GI practices have relied largely on colonoscopy. But if you see some of the large practices, a lot of the revenue is not coming from GI services alone, but there's a dependence on ancillary reimbursements and revenues, and that's only going to increase, right?
I
So.
think so, and I think the model will change too, so that if so part, when we first started to consolidate it, the idea was so we could build other revenue streams and have enough volume. But I think that's morphed a little bit. So now, if you think of you know, if you think of we want to control costs and population health and the experience of the patient, right? Um, so as we change the way we think about reimbursements, all these things, now we can control every bit of cost. And so we can take that to the marketplace. So if we can keep people out of the ER, if we can do those things, we're going to take that and do um, different types of negotiations with payers and think more about populations. So can we do chronic care management? And if we control every bit of cost, we can have alternate payment methods that we can take to payers. So these ancillary revenue streams can be ancillary revenue streams, but also controllers of costs. Because, I can do a CAT scan for a hospital can't do a CAT scan for $1,000 and make a profit, and I can make a profit on a high quality CAT scan for a lot less. And I think we can start leveraging those types of things. Our infusion centers will be great cost savers. So
Mhm.
while they're ancillary revenue streams, they're great cost savers. And so as we get to this fewer direct touches, but more remote touches, and thinking of populations and doing all that stuff, all these things, if you have them, will be great for the patients. It'll streamline everything.
What was your vision when you started Gastro Health, and when went after private equity, created the platform, and built up this large practice that you have now? Like, so what was the uh, original vision?
Well, I think I always thought doctors had it to consolidate. As I had said before, it's imperative for us to lead healthcare reform. We're the best advocates for patients. I think we're the solution to many of the problems that are in a healthcare system, and I thought we could build a more disruptive model that would really make a difference. And we needed to get larger to be able to do that, and we need to be capitalized. So there's a lot of different models. That's how I came up to go to private equity, because we needed all those things, and we needed something that would be a catalyst to growth, because it's very hard to grow otherwise quickly. It took us 10 years, about 8 years to go from 27 to 47, and it's taken us 3.5 years to go from 47 to 250. So it's a catalyst to growth. But why did we want to grow? Not just to get bigger. That's not the point. It's what can we do with that? So I think everything's going to be on about data. And so what were you trying to do? We want to build data warehouses and data lakes, and we want to be able to we already have a robust business intelligence platform, but now how can we take data from disparate sources, put them in a data lake, and start to do analytics and predictive analytics How can we do all that stuff? Well, if you're a 4-person group, you can't. Um, but if you're 500 doctors, you can. Number one, we're capitalized. We have so we can start to build those things. And number two, we can spread that expense over 500 doctors because it's hard to do. We were actually starting to work on all this pre-COVID. It's been delayed a little bit because we had to do other things, but we'll get back to it. So that was the vision, that we needed data to drive better outcomes, to be predictive, to take care of populations. But a small group couldn't do that. They don't have the wherewithal. They don't have the ability, the money, the capitalization. By being large, you collect large amounts of data, and you have the wherewithal to do something with that data to make a better world and better outcomes for our patients. That was what this was about. And it goes back to your original question about, is the downside of private equity. As long as that remains what we're about, I'm not worried about our private equity situation.
Your practice was the first one to take private equity. Now, that was back in 2016.
Yep.
And typical private equity horizons are 5 to 7 years. So, my own calculations always have been that, I'm going to see Gastro Health exit probably at some point. That second bite of the apple is possibly going to begin for GI in 2021, 2022. And now all this has, COVID has paused everything, put things on hold. Based on whatever you can share and know and all that, like, so I'm curious to know, would all these exit horizons change? Like, so would it all be longer now? And what would determine an appropriate time for recapitalization, in the GI space?
Well, I'll go back to my original answer. I think the deals have slowed down. That would be another deal, right?
Yeah.
So I think the deals have slowed down, and we'll see where the market comes back. If we can get back to doing deals by the end of the year or first quarter 2021, maybe we'll be behind by 6 months to a year. We'll see. And then you have to understand what the appetite of the next buyer is, right? I think that's all to be determined. Would I have preferred if this never happened? Of course, but for more than just a private equity deal, right?
Yes.
Right.
Yeah. I've covered a lot of ground on the questions that I had. Was there anything else that you wanted me to ask? And we could do that now.
I think it's been an interesting experience, and I hope we all take it as a learning experience. What can we do to be better? We need to be better. And all through this, what I'm amazed at is healthcare, and how passionate we are about it. So that's a good thing.
How do you make it better?
Well, we talked about it. You can be more efficient. We can touch the patients more. We can, and all those types of efficiencies, I think, has been spurred. I think televisits will have better touches and more frequent touches with patients. I think we're looking at being more efficient. I think technology will be better. I think we'll start talking about populations and taking care of our people in different ways. I think this has spurred us that we don't have to see the patient in the office to take care of them.
So Jim, like, we've gotten ourselves into this, right? Like, as a system, as a healthcare system. And for me, like, when I reflect on this time, a part of me, is saying that, like, we asked for this, in a lot of ways. Like, so we've created the inefficiencies, we've created the wastages in the system, we've created this whole monstrous, expensive system, and we have kind of trapped ourselves. And somehow, we're not able to use, the system that we have created to solve the problem that has hit us suddenly and across the
Be-
board. Uh, it,
because I don't think you, I mean, it's the whole concept of disruptive innovation, right? It's the whole concept. You need something disruptive to change. You can't say, if you want to change the health system, this is my philosophy. And one of the reasons we did what we did is you have to be disruptive. You can't say, oh, how can we use the current system to change? Because the current system is a monster. And so you need to think about things in a different way. And so I'd love this disruptive thing to spur innovation. And I think it will. So I think that this could be the seed of disruptive innovation for the future. And we can't do things the same old way with the same old systems and the same old processes. You'll just get the same results. So I'm hoping that this is the seed to start to think about doing things in a different way. And I think it is. I see that within our own company.
yeah. Well, thank you very much, Dr. Leavitt. This has been a fantastic conversation, very reflective too. Was there anything else that you wanted to add before we close?
Thanks for doing all the stuff that you're doing. I think you're keeping people informed, and you're doing a great service for people.
Thank you very much. Thank you so much for saying so.
All right.